Well, our next speaker, all the way from the UK, Dr. Keith Grimes, who I think describes himself as a lifelong gamer and nerd, maybe. I think that's what you said last night. I'm putting words in your mouth. Maybe I'm saying what you... Oh, geek. I'm sorry, not a nerd. It was a geek. A gamer and a geek, the two Gs. And really wanted to just work with computers and games and decided that at some point he should probably do something that, would pay the bills and became a doctor. But he's brought the two together and for a long time has been trying to understand how to use technology with his patients. He's a general practitioner. Again, in the clinical trenches, taking care of all different types of patients, from neonates all the way up to adults. And his work has spanned everything from neonatology-based sort of technical innovations to using virtual reality for delirium in the intensive care unit. And very patient-focused, which is why I'm really so happy that you came out here today. And we're going to be seeing some examples of him interacting with his patients and what his experiences have been along the way. So without further ado, thank you very much for flying across the pond and being with us here in Los Angeles.
Thank you. Well, hello, Los Angeles. My name's Dr. Keith Grimes. I'm a general practitioner from the National Health Service of the United Kingdom, and I am delighted to be here. And I'm honored to have been asked to come along and speak at the inaugural Virtual Medicine Conference. So today, I'm going to tell you a little bit more about how my practice became virtually better. How virtual reality is easing pain, calming nerves, and improving health in primary care. So to help orientate you, I'm going to tell you a little bit more about general practice and primary care in the UK. Now, whenever I come out to the States and people ask what I would do, I tell them I'm a GP, and then people aren't entirely sure. So maybe you do know, but if you don't, a general practitioner or general practice is a speciality in its own right in the UK, and general practitioners are akin to a community consultant generalist. And there's quite a few of us. If you look at this map here, there's 50,000 of us across the United Kingdom working out of about 9,000 practices. And this number is rising too. But it's not rising quite fast enough. If you look at the statistics, for example, the UK population of over 85s is set to double by 2030. So it's going up, but not quite fast enough. And general practice is very much the gateway to the NHS. And we see about 90% of the patients, or 90% of the consultations. Back in 2014, 340 million GP consultations took place in a year. Now that had risen 15% in the prior 3 years. The average patient sees their GP 6 times a year, and that had doubled in the previous decade. So like you, we're all pretty busy. And we see all kinds of patients in general practice. Like Brennan said, we see babies, we see adults, we see everyone in between. And every patient has a unique story. But within those unique stories, we tend to see some things more frequently. And pain and the management of pain is one of the most common reasons that people will come to us. So this data here is taken from a Scottish survey taken back in 2013, which lists the top 10 reasons that people present to their general practitioner. So if you have a look, you'll probably recognize some things in there. And if I highlight those areas where people will present with pain or anxiety, you get an idea of the burden of pain and anxiety in patients that come and see us. So how about practical procedures? Well, we also do a lot of practical procedures such as blood testing, immunization, wound care, joint injections, and minor surgery. And again, if I highlight those ones where pain is pretty frequent, you can see right at the top, we do a large number of blood tests. And that's significant because between 3.5% and 10% of the population will have some degree of needle phobia. And that will lead them to potentially delay coming to see their GP or maybe not have treatment that they might need. So, how do we manage pain? Well, we have a number of options in front of us, and because of pressures, we've got less access to musculoskeletal clinics, we've got less access to pain clinics, and mental health services are chronically underfunded. So we turn to opioids, and where America leads, the UK follows, and I'm afraid we've developed an addiction to prescribing opioids as well. Here we have an article from the BBC a couple of weeks ago, which was talking about the rise in opioid prescriptions. So to give you an idea of what it is in the UK, nearly 24 million items of opioids were prescribed in the NHS England back in 2017. Now that had risen by 10 million in the previous 10 years. That's a near doubling. And it equates to about 2,700 items per hour. And sadly, deaths from opioids, either illicit or prescribed, are also rising in the UK. comes to about 10 a day, I think, when we did the calculations. So it's still a large number of people. And it was interesting seeing one of the points made earlier on about friends giving friends opioids, because actually in this same survey, 2 million adults are estimated to have taken a prescription medicine that wasn't intended for them. So what are you to do? We're finding it difficult to get hold of musculoskeletal services, we're finding it difficult to get hold of chronic pain clinics. So a geek like me, what am I going to do? Well, I'm obviously going to turn to technology. So this is me in 2015. I bought myself my first Gear VR headset, and I have to confess that I bought this not for medical purposes, but to entertain myself. And very entertaining it was too. But through the process of using this, I got very used to that incredible property of virtual reality, that sense of presence and immersion that you get. Now, I got introduced to virtual reality as a medical student back in the early 1990s, and I was aware of some of the evidence base going forward. But again, remember, I'd got this and I was using it for, for entertaining myself. So at this point, I want to introduce you to the person that really taught me the importance and power of virtual reality for managing pain.
Hi, I'm Isabella. I'm a mother of two, and I'm an artist.
And Isabella's a wonderful person. She's one of my patients, and I first met her back in around about May 2016 because she was having problems with dressings. She was having to come in for daily dressings, and the nurse told me that she was really struggling trying to control the pain. I mean, Isabella was crying through the procedure. It was taking an awful long time, and she was having to get this done every day. So Isabella, what was it like having your dressings changed?
It was very, very complex process, really, and a very, very painful. The most painful part was to take the drain out of the wound, and the nurse had to change it every day. So and there was about 12 centimeters of the thread going into the wound. So it was extremely painful doing that without any painkillers. Because I was having those dressings done just after having a baby. I couldn't really take anything else but paracetamol because everything went to my breast milk. So I was taking a regular paracetamol, but it didn't really work because it was very different pain type of the pain. So it didn't work at all. I was really afraid to walk there every day because the dressing were done in the mornings. So that's how my day started. And I was all sore from the birth, from the labor already. So starting the day from such a pain, it wasn't really what you want as a new mum.
Well, she's not joking, is she? I mean, can you imagine waking up every day a new mum and being fearful about what that day is going to hold for you? And her story isn't atypical of patients that need wound care. There's an awful lot of pain, and in her case, she had the complexity of being a breastfeeding mother, and so limited analgesia options. Other patients may have other complexities too. So at that point, I thought, well, we're coming towards the end of what we can do inside primary care. But remember, on that day, I had my VR headset. And a few days earlier, I'd seen Shafi Ahmed, who you heard mentioned earlier on, and Dan Kraft, doing the world's first 360 broadcast of an operation going around the world. So if Shafi can do this and do it for everyone around the world, I thought, why can't I just do this for my patient? So I did. I asked her, I said, explained what virtual reality was, and I said, what did you think when I suggested trying virtual reality?
I thought it straight away, it's a fantastic idea. I was curious how that distraction would work, because, I didn't really have an idea how that would work, but I was so curious. I was really fascinated to try.
It's curiosity. And isn't it interesting? I mean, actually, this is the typical response that I get from the patients in my personal list. They're intensely curious about the idea of doing this. And I haven't seen any difference in ages of patients to differ this. The younger patients, the older patients, they're all very interested in trying. Now, that's maybe just down to the fact that they're signed up to the personal list of a doctor that's such a geek. And I've tried other tech before, but it is very interesting to see them do this. So we went through to the nurse's room, we got the Gear VR headset, and we put it on for her. So what was it like using VR?
First of all, because it was the first time I actually used the virtual reality. I was so amazed that I didn't even feel anything. I was so much, the virtual reality drawn me into it so much. And plus the video was very funny. So, I just I didn't even realize how quick it went, because usually it was about 15 minutes. And with virtual reality, it was just like a click of the fingers. It was so quick. So I was amazed how, how it distracted me from all the pain.
I mean, I was amazed too. And of course, she's obviously a very strong responder here as well. But since then, I've used this for many other patients. And some of the things that she mentions, I've seen time and time again. That sense of time being shortened, that sense of reduction in pain, and sometimes high levels of distraction. And also that strong first use effect. And actually that first use effect was something that I was worried about. And in fact, I alter for patients, I alter their experiences to try and get over that. But I'm pleased to hear earlier on that there seems to be some persistence of the effect of virtual reality despite that. So, we found her using this. She's found it very, very effective. Was there any differences between the experiences?
I think, I liked all of them. We also used the Rio de Janeiro dance lessons.
Oh yeah.
That was very good one too, because it was 360 degrees. But then again, because of I couldn't move, but I was so I don't know how did that affect changing the dressing. But it was all of them were working so good because it was so new.
But isn't it interesting that she already highlights one of the problems, that the use of VR might in some way interrupt the clinical procedure that she's having. So this is important. This is important that we choose the experiences that patients have to suit the procedure that they're undertaking, or even maybe work with the patients to develop those experiences. So we managed to use virtual reality 4 more times that week, and each time it was really effective for her. And I'm really, really pleased to say that she healed up lovely. And she's since had another child, a little boy called Julian. And the only thing that I regret is that I didn't offer her virtual reality for the labor. So would you recommend it to other patients?
Yeah, I would totally recommend it. I would, it doesn't have any effect of your physical body, because you don't drug yourself with any drugs, and it's just distracting so well that it just, I was just in it. So I wasn't aware what's going on around me. So I would absolutely recommend it if I would have to have, changing dressing, pain,
Yeah, no, sure. I hasten to add that I haven't paid this person. And also I'm appreciating that this is just one case study just here. And of course, it's important to build for the evidence. But hopefully you can see the impact of something simple on a real patient. So what are the things that I've learned through the use of VR thus far? Well, I've used it on a mixture of patients, mainly for wound care, but we're also doing blood samples and immunizations. It's generally very well accepted. And we've been lucky enough to be using Bear Blast from Applied VR. And so we've had that explained a little bit earlier on. It's an interactive game, and the combination of the simple motion mechanic, where you move your head to throw balls at these teddy bears, and that it continues to run, makes it very, very useful for patients in these situations. Now, I've seen VR work best for patients with high anxiety levels. It seems to reduce their pain to a greater degree, and that's interesting because that fits with the research evidence, and also it seems to be what we're hearing from other people. I think that immersion is good, but interaction is better. And it's great that I was sitting through all the talks earlier on, because it seems that that's also a feature that other people have noticed. And then when it comes down to this class effect and specific effect, what I mean by that is that it appears that virtual reality has some effect regardless of the experience, as though it's like a class of drugs. But what we're really interested in is what are the specifics? What are the specifics of an experience that might deliver a beneficial effect to the patient? Now, I'm a convert to VR, but there are some problems. First of which is that we've been using Samsung Gear VR. It's a really, really lovely piece of hardware, but it's slightly complex to use, and we've got hold of a Pico Goblin now. And actually, people are liking that with a standalone. And this is the year of standalones coming out. Clinical grade, we're looking for those that, we can work around and make them suitable for use in practice, but it'd be nice to have one that we could take off the shelf to do that. The nurses are always asking me to help them out with this. We need to standardize procedures, much as we heard earlier on from Matthew. The range of apps is relatively small at the moment, but it's growing every day. But I find it quite difficult to switch between the apps. Actually, I think the Applied VR platform probably solves some of this as well. But if you want to have a large range of different experiences, I'd like to make it very easy to switch between the two. They need to be tailored to individual use cases. We need to deal with different languages. You may be able to tell, but Isabella's a Polish lady, and there are other patients whose English isn't quite as excellent as hers. And I'd like to see screen mirroring and external controls. But again, in the exhibitors here, some people are addressing this already. So this was before, and I set out to try and solve these problems. And like a kind of practical-minded person, I reached out to my local community of GPs, but there wasn't anyone really doing this. So I decided to go online and form a group, and thus VR Doctors was born. So this is an online community, free to join. We've got about 500 members now, and it's a group of doctors and patients and developers and academics who are all focused on sharing information about clinical immersive technology. And through this, we use different methods to try and address some problems, and I'd like to tell you about 3 of them today: Calmo, Prevent ICU Delirium, and PR in VR. So first up is Calmo. Now, everyone here heard of hack days or hacking events? Those that have, those that haven't, it's essentially a way where you get a group of people to come together over a short time period, you fill them with coffee, and then you get a solution at the end of the time. And they're increasingly popular in medical circles now. And one of the ones that I really like is this one, the NHS Hack Day, which has been going for a few days in the NHS. And it happens several times a year, so I've been to 3. And in January of this year, I went across to Cardiff in Wales, and I took across one of the problems that I mentioned before. In fact, I didn't even mention it that much. One of the problems with a lot of the solutions is if you have a patient who needs addressing and they need to lie on their front, a lot of the experiences don't really suit that. So I went along looking for a solution for this. But actually, I heard someone else pitch an even more interesting problem, which was procedural distraction for blood sampling. So what happened was we formed up a team. By 11 o'clock, there was a pitch, and we formed a team. The names of the team are just here on the right. By 3 a.m., we'd managed to create a working prototype. We tested it the next day, and by 3 o'clock in the afternoon, we were awarded one of the top 3 prizes in this little soiree. It was great. But the thing that was really, really interesting to me was that by Monday morning, less than 2 days after we stood up and asked about this, I was using it with patients. So we went from pitch to patient in 48 hours. And I think that highlights the power of hack events, the power of working with patients, and it's also an interesting glimpse into the potential future of how virtual reality might be used with patients. So we don't take off-the-shelf pieces, or we don't customize them. How do we create this? Do we create this in social VR with patients? So from events like this, I've met a few people, and one of the people I want to tell you about is a consultant cardiothoracic surgeon called Sunil Budhia. And he came to me because he had an idea. Now, Sunil has patients that need to go to intensive care. It's the nature of his work. And a proportion of those patients develop post-operative delirium. And for those that don't know, post-operative delirium is, hard to say, is a condition where people have a period of cognitive impairment, which can delay their healing. It can lead to longer stays in intensive care. And as a result, you can have worsening outcomes. Now, previous studies have shown that if you take a patient through to ICU, you can diminish anxiety, you can diminish post-operative delirium. So the question was, can you use VR to emulate this? And we believe we can. So we believe that by using high-quality immersive 360 video, taking patients before their operation through the whole procedure in the hospital, we can help drive down anxiety, drive down post-operative delirium, and maybe even build some resilience to help address some of the problems with post-traumatic stress disorder that come from a visit to the intensive care unit. We've paired up with a company called Medical Realities, and we're using Samsung Gear VR, we're using 360 cameras, and we're going to a small-scale trial later on this year. And this is psychological resilience through VR exposure as a novel therapy for ICU delirium, or prevent ICU delirium. The third one I want to tell you about is about this gentleman here, PR in VR. Now, through VR Doctors, when I started, I thought I was going to be the only person working in primary care that was interested in virtual reality, but that wasn't the case. This guy here, Farhan Amin, is a GP working in the northwest of England in a place called the Lake District. And this award-winning GP had developed something called PRNVR, Pulmonary Rehabilitation in Virtual Reality. So pulmonary rehabilitation is a program of education, exercise, and support that helps patients with chronic lung disease to function to the best of their abilities. And it's so effective that guidelines in the UK state that if you're admitted to hospital with chronic obstructive pulmonary disease, that you have to be referred for pulmonary rehab within 4 weeks of discharge. Similarly, if you have COPD and you have any kind of exercise impairment, then you're to be referred to pulmonary rehab. But as you can all imagine, all those referrals to pulmonary rehab lead to a big build-up on a waiting list. And PR and VR is Farhan's attempt to bridge that gap.
Classes like these, not just here but all over the country, are really oversubscribed. For every person here, there are 10 on a waiting list. So here in Barrow, they're trialling a scheme using new technology so people can get this kind of training in their front room. Technically, Pauline's in Walney, but in her head, she's on an entirely different type of island.
I'm on a beach, and next to you is a little swimming pool, and out there is the sea.
Pauline's watching a virtual instructor who's setting out her own personal exercise class. While she does her stretches several miles away, her GP can measure what she's doing and what effect it's having.
So the sensors that are built into the headsets allows us to performance measure patients' activities in their own home. So it gives back patients their independence. They can do their activities in their own home, but it maintains the oversight of the clinician.
And if he sounds like an expert, that's because Dr. Amin invented this.
It improves patient retention by up to 80% because it removes all distractions. You can see how concentrated they are and completely detached from the surroundings.
We're on the beach.
So what do you like about it?
Well, you're relaxing, very relaxing. All the stuff's there in front of you. You don't see anybody around you. So it's all nice and warm and cosy.
It's like a trip to LA, nice and warm and cozy. So he's had some really encouraging first results. I mean, patient activation measures have improved in the first cohort over 6 weeks. He's seen some reduction in anxiety using GAD-7 and depression during PHQ-9. And he's, as a result of this and his work, he's been appointed as the first AI and VR lead for Lancashire and South Cumbria Sustainability and Transformation Plan, basically a group that commissions care for a large geographic area. So it's going to be really interesting to see how this develops, and hopefully we'll have a demo of this set up for you tomorrow. So what's next? Well, look, I hope I've basically given you an idea of how even small interventions can make a significant difference for patients. But we need to start scaling this. We need to start moving outside hospitals and moving into the community, into nursing homes and into hospices. We need to diversify the availability of apps that are available to be used. And we need to share our understanding, our knowledge, at events such as this. We need to be creating new experiences, working with patients, not only to identify their problems, but find those things that they find preferential. And we need to be contributing to the evidence base, either through our local academic links or through something like VR Core. I'm focused on the safety aspects as well. I'm working with NHS Digital to look at creating safety cases that we can help instruct developers and those that provide care. But I think the most important thing is that we share some of the information that we're learning today, because VR is already easing pain, calming nerves, and improving health. We just need to let people know about this. And I think it's important that we leave the last part to the patient.
Definitely.
Yeah.
Definitely. Especially if you look about, like, kids. Now I'm having two kids, and for them would be so good. Even with injections, with vaccinations, that would distract them. So it wouldn't be so stressful for them. I think it's an absolutely amazing idea, and it should be used worldwide.
Thank you very much, Isabella. Thank you to Brennan and the faculty. Thank you to the audience, and thank you to everyone listening at home.